and that is Sheela. So Dr. Sheela Sadruddin has been part of human IVF since 2008. She is a certified as high complexity laboratory director and technical supervisor by the American Board of Bioanalysts. She has served as an inspector for College of American Pathology, CAP, and she serves as a panelist for NASA Space Biology Research Program, as well as worked in the United Nations as an expert reviewer for PCR test platform for COVID-19. Currently, she is a laboratory director in few labs in Frisco, Texas, and San Francisco. Sheela, thank you so much for joining.
Thank you for having me. I think all of the presentations so far have been fabulous. My portion is going to, of course, go over, but more importantly, I'd like to talk in detail about ICSI. So let me go ahead and begin. Do I have control? Let's see. If I can go to the next slide, please. So one of the things that I haven't heard stated yet so far is that there is clearly a difference between day 5 and day 6 embryos, which we all know. However, the biopsy procedure itself also is very different. So here on the left, you see an image of the early day 5 embryo versus on the right, it's a more advanced and a day 6 embryo. So go ahead and play the day 5 video, please. And here you'll see the biopsy procedure, of course, but what I want to focus on is that the trophectoderm cells of this embryo are larger comparatively speaking to the embryo on the right, which is a more advanced and a day 6 embryo. So in that, you're going to notice the junctions are more visible. And as the cells are being stretched out and the laser is hitting right at the junction points, the tearing of the tissue is easier, it's simpler, and it's much quicker, which is why you get this notion of, day 5 embryos are easier to biopsy. Biopsy procedure. So you want that, as you can see here, you want the bulbous cells, you want them alive, certainly, and you want them not flat and grainy, so that way you can load them easier. And now if you'll go ahead and play the day 6 embryo biopsy video, please. And then here you'll see that even though both of the biopsy procedure is going to be different in that obviously you have a more advanced embryo. So you see a larger group of, or more cells that are hatching out of the zona pellucida on when I'm training. And then once you get that stretch and you see those junctions, you want to hit those junction points and you see perforation. And once you're perforated through from the top to the bottom, then relax a little, pull your cells into the embryo biopsy pipette, and then a quick pull away should get your embryo biopsy to fall off. Continuously throughout the entire embryo will cause a applying laser pulses is that we reposition our embryo herniated out of the zona pellucida, and then that allows us to then stretch the biopsy where we can easily just break it off. So just know the differences between the day 5 and the day 6 embryo, and know that you're not going to always have the same approach when you're biopsying the various stages, even though both of them were hatched. Next slide. All right, so here, this one is a completely hatched embryo. So if we can go ahead and play that. This holder, you can't see that in this image, here, but of course, this um, harder to get to with the laser. And so that you want to have limitations during your procedure. So what I want to focus on and what I recommend is that the hole diameter is very important, and that you don't want to apply too large of a hole diameter from your laser, so that way you can limit the heat and the pulse width. So the hole size that I recommend generally is anywhere between 7 and 9 microns, and with pulse width of 0.5 milliseconds. Your target for the laser should always be between the cell junctions. You don't want to necessarily ablate the cells themselves, because obviously that's going to create a charring effect of the cells, where the cells they appear dead, grainy, and flat. And so it's definitely going to present a more difficult biopsy in that they won't stretch away. However, if you target the junction points, and it'll be much smoother as far as going ahead and being able to remove that piece entirely. And so as you can see here, encourage my staff when I'm training that the embryo biopsy should be moving too much in the biopsy pipette. So some of the key points that I'd like to address is that you want to create a seal inside of your biopsy pipette. So as you are aspirating the few cells inside of your pipette, you want to have them completely hug the inside of the pipetter, so that way it creates this seal. And so long as you maintain that seal with a little bit of blastocelic fluid inside of it, then you are going to have a better control of your biopsy. And then as you're stretching that biopsy away from your embryo, you'll notice that it's not flying up your pipette, where you can potentially lose it. So the rate of loss of a biopsy is minimal, if any at all, in our lab, because we try to focus on maintaining that seal. Also, spend the time in the very beginning to set up your embryo. Make sure it's in the right position. Make sure you have enough cells to biopsy within your pipette before you start going ahead and applying the laser pulses, because this way you're going to spend less time fighting with the embryo procedure, and that you want to safely get that biopsy away. The tension that you apply to the stretching away of the cells, you certainly want to make sure that one of the main things to focus on is that the biopsy procedure is to make sure that you have a usable embryo. So instead of focusing on mainly the biopsy, you want to make sure that you focus on making sure that your embryo itself is healthy and it's doing well. So just keep that part in mind. The last thing that I'd like to focus on is that pet and the very important. And so give me 1 second as I connect. So hopefully I'm not breaking up so much. I see some comments that my voice was breaking up. So I'll keep an eye on those comments. So the last thing I wanted to go ahead and address here is that the inner diameter of the biopsy pipette and the holding pipette are also very important, in that if you have too large of a diameter, then your controls are going to be much more lax than if your diameter of the holding pipette and the biopsy pipette are much tighter. So see what works for you. Certainly, we have a consensus in our lab that the smaller inner diameter tends to have better control. And one of the presentations that I saw, the very first one, Dr. Winninger, he showed a pipette that was beveled on that had a smaller in opening. So that certainly helps with the controls. Roughly about 25 to 30 microns inner diameter tends to work the best. The biopsy procedures that you saw here were a 40 micrometer inner diameter, so slightly larger than what I'm mentioning. Okay, next slide. So let's go ahead and shift focus to ICSI, so intracytoplasmic sperm injection. Whoops, can we go back a slide, please? Thank you. Okay, so many of our new embryologists and sometimes even our senior technicians don't really know the history of ICSI. ICSI was first introduced in the early 1900s by Dr. Gian Piero Palmero. From Cornell. So in 1996, ICSI was primarily used for male factor cases. I'm sorry, that's a typo. And so over the years, more and more labs are transitioning over to an all ICSI program, regardless of whether or not the patients present with a male factor. So, of course, to date, now there's roughly about 70%, over 70% of the labs are using ICSI for non-male male factor cases. And then for cycles that are without male factor, ICSI is associated with decreased rates of implantation, pregnancy, and live birth when you're comparing that to conventional insemination cases. Now, ICSI does present with a risk, an increased risk rather, of genetic disorders to offsprings in that 4.2% versus 3% when you're comparing it to the natural population in conception. Many of these risks are due to patients that present with congenital bilateral absence of the vas deferens or Y chromosome microdeletions, such as AZF, A, B, or C in the C regions. Of course, oligospermia, azoospermia. And these are important when we're determining whether or not offspring are then affected with genetic disorders. Obviously, if you're using sperm from a male that presents with a male factor, and we're creating offspring, which otherwise he would not be able to do, the chances that he's passing on that genetic material and his offspring will then also inherit that genetic disorder are more so likely than someone who presents without a male factor. So imprinting disorders, the non-Mendelian inheritance type of disorders are also something of concern. Defective imprinting of gamete DNA along with ART procedures themselves are said to be potential causes of these defects. Of course, literature in this area is not as ample as you would see in some of those other areas. So of course, this is a very hot topic, and we certainly would like to learn more about it. Now, the image on the right is very interesting because although we know sperm is a very small cell, the ICSI needle that you see here on the top is it shows that it's roughly about 5 microns in the inner diameter. And right below that, you see a human hair, which is about 50 microns in diameter. So it just goes to show you the size and appreciation of the fine ICSI needle. And of course, you know, we have it that size because we want to present the minimal amount of stress on the single cell, which is the oocyte, to minimize any damage or degeneration while we're performing the ICSI procedure. Next slide. And so here, I've heard a few panelists state that, you know, we'll go ahead and ICSI using the polar body as a guide. We want the polar body at the 12 o'clock position or the 6 o'clock position, but just, you know, let's go ahead and just talk about why that is and what research has led to us practicing this way. So of course, this right here is a ICSI video, and several cells will be ICSI'd. So here we're using the polar body again, also as a guide. We'll go ahead and hold the zona firmly against the holding pipette. We'll advance the needle through about 50 to 70% of the way through the cytoplasm. aspirate, we'll make sure that we'll have that break and then slowly go ahead and deposit the cytoplasm back into the cell, and then of course the sperm to follow. And then that tuck that you see is we're making sure that we take that sperm and it is touching the cytoplasm, so that way we make sure that to increase the rate of fertilization. Now, going back to the polar body placement, 11 to 1 o'clock, or alternatively 5 to 7 o'clock placement is ideal, because if you look at that image on the left-hand side, you'll see that a study performed looking at the spindle placement shows that the spindle is very close to the polar body. And so what we would like to do is, we don't want to damage that spindle, because it's responsible for proper segregation of the chromosomes, and then of course later cell divisions. So that is primary reason to place the polar body where we do and where it's recommended, because we certainly want to avoid any damages. Now, the speed of the injection, over the years, I've heard several embryologists say, oh, there is a right speed. You want to inject your sperm not too fast and not too slow to improve your fertilization rate. I truly do believe that there is a proper method of ICSI, but certainly whether or not it's related to the speed of how fast you're injecting your sperm back into this cytoplasm is certainly a myth. We have technicians performing ICSI at various speeds, and we too, like many of the other lab directors, perform inter-tech comparisons. And one of the key point indicators is, of course, we want to look at fertilization rates. So similar fertilization rate with various speeds. What you want to make sure, and what's very important, is the key points down at the bottom left-hand side here that you see, is that you don't want any residual PVP inside of the egg cell. So really, the slower your injection is, the more likely it is, especially when you're a new embryologist, to go ahead and continuously deposit residual PVP post-sperm injection into the cytoplasm, which can then ultimately reduce your fertilization rate and perhaps increase your degeneration rate. So something to consider when you're training, or if you're already trained and wanting to improve your fertilization rates. So those two key points. And then that once the sperm is deposited into the cytoplasm, going ahead and placing your needle right under the sperm head and pushing that up against the cytoplasm to make sure that the membranes are meeting certainly is, again, something that we practice, because we notice that it certainly helps with the fertilization rate, to make sure that there isn't any a pocket of fluid that the sperm swims around in, versus that it's connected to and touching the cytoplasm on the cell. Now, the needle placement is also important, in that you want to advance your ICSI needle at least 50% of the way from the zona pellucida to the center of the cell. 50 to 70%, I have found that is the sweet spot, so to speak, and tends to work really well. We've seen some various techniques, but in our lab, certainly this tends to work perfectly. So we'll just watch this again. The sperm is right at the tip. You're advancing through the cytoplasm into the center at least 50%. Aspirate up. As soon as you see that break, go ahead and stop out. And then you'll go ahead and deposit that sperm. The needle will come right under the sperm, and then tuck it back up. And then that should, go ahead and remove the needle, tuck, and then move the egg. And that completes the ICSI procedure. So if you can go to the next slide, please. So now I'd like to just turn our focus to a case review. So we focus so much on our techniques and making sure that we're training properly and we're practicing significantly to improve our overall outcomes, which are all very important things. But there are many things that are just unexplained. And this, to bring to your attention today, is a case review. And this is a nulliparous female that presented to us 31-year-old, and on the right there you see her, a snapshot of her diagnostic history. She's been trying to conceive for 7 months, partner's essay within normal limits, and she presents to us as a primary ovarian insufficiency or primary ovarian failure patient. And so on the right there in the center where it says prior fertility tests, you'll see that those were her primary tests, and then we performed repeat studies there in red where her basal FSH was 7.9, which is within normal range. Her TSH was 0.75, which is a little lower than expected for a female at her age, and her AMH tested low, especially given that her FSH was normal at 0.6. So we knew that there was certainly, in combination of that and her AFC, which is antral follicle count, it was very clear that she had lower reserve to present with. And there at the bottom where you see all those bars with cycle ID numbers, it shows you that she had 3 failed IUI cycles, which otherwise we would expect for her to then conceive in at least one of those cycles. So then we decided we're going to go ahead and take her through to IVF. So she ended up doing 3 IVF cycles, and then 1 FET cycle was at a later point. But let's go ahead and go to her first cycle to go ahead and review that. Next slide, please. Okay, so here this cycle, when we had her eggs retrieved, we were all surprised to see the oocyte morphology of the at retrieval. So here's an image of what we see. So right off the bat, you can see that the cells are granular. They're coarse in morphology, and then they're also irregular shape. That's the eggs themselves. But very obvious defect here you see is the zona pellucida morphology. You see fragmented zona pellucidas. They're striated and they have a rough appearance. Of course, you see also the debris in the cytoplasm and large PBS spaces, which is just less than ideal and suboptimal. And so we'll see that throughout all of our IVF cycles for this patient. So let's go ahead and go to the next slide. Here is a snapshot of her first case. So despite the normal ganirelix antagonist cycle, we saw that the female recruited 3 oocytes. And there on the top left-hand side, you see that image, that same morphology, the coarse and graininess. We had 2 we exceed 2 eggs. Only 1 was mature. So maturity rate was a factor despite her responding to the treatment. During simulations, only 1 egg was mature out of the 3. 1 egg was immature. We went ahead and exceeded it anyways in hopes that it might fertilize. And so it did. So the next day we notice that we had 2 oocytes that fertilized normally. However, they failed to divide. They arrested at the cleavage stage here, and this was an unexplained case. We thought perhaps maybe we can correct for her response. So in the next cycle, we went ahead and did that, and we used a microdose Lupron protocol. Let's go to the next slide, please. Excellent. And so in this cycle, we noticed that we had this exact same morphology of the oocytes. And so we saw the same zona pellucida defect, which then we knew that perhaps this defect was now related to embryo development and cell morphology more so than just a zona pellucida protein defect. And so here we had recruited a higher number of eggs. Last cycle were 3. This cycle we had recruited 11 oocytes. We went ahead and performed ICSI on all of the oocytes that were mature. We saw that there were 5 that fertilized normally. However, morphology was extremely poor in that we had abnormal shapes of cells, very dark and coarse granular cellular cytoplasm. And so we were certainly concerned. We did notice that on day 5, the embryos were highly fragmented and many of them arrested at the cellular stage. We did have blastocysts develop, however, they were not usable. They were very poor quality and unfortunately resulted in a negative cycle. All right, so the physician and the patient wanted to try one more time. So against all of our recommendations, they went ahead and tried again. So if we can go ahead and move over to the next slide. This is cycle number 3. And so here we saw, again, we used the microdose protocol, and we were able to recruit 7 eggs in this cycle. 4 of those eggs were mature. So we went ahead and performed ICSI, and the outcome was suboptimal. Again, same morphology. The zona pellucida just appeared very fragmented and almost worse in this cycle. And so we had 2 eggs that had fertilized normally. Of course, the patient was set up for embryo biopsies, which we all knew was very, very unlikely. And so on day 5, we noticed that there was a morula. I think we were extremely gracious and calling it at that. On day 6, we noticed the image on the bottom right. It's an early blast. Again, a very generous grading. It's barely a cavitating morula. So the embryo development was very poor, in that we did not recruit any oocytes that resulted in usable blastocysts. So unfortunately, this patient was not able to conceive using her own eggs. Now, we were at a loss. We did some literature review, and I'll present that in my next slide. But before we go to the next slide, I wanted to just go ahead and take a moment. So right after this, the patient then decided to use frozen donor eggs, which is the last FET cycle that you saw on that screen at the beginning of the case review. Now, using donor eggs and partner sperm, of course, we did a single embryo transfer, a blast transfer on day 5, fresh embryo from thawed frozen eggs, and the patient was able to the embryo was implanted, the patient was pregnant, and the patient should have already delivered. I tried to get the pregnancy outcome before this talk and it was unable to, but we expect a live birth from this cycle. So despite her oocyte recruitment being suboptimal, and we noticed certainly a infertility of an unexplained origin here, we were very happy to see that the patient was able to get pregnant using donor eggs. Let's go ahead and go to the next slide. So here, the 3 cycles that we went ahead and completed for this patient, we saw that there was an obvious zona pellucida defect, and the patient presented with preliminary ovarian insufficiency that was impacting her embryogenesis. And we know that it was likely due or from an abnormal oogenesis. So POI, or preliminary ovarian insufficiency, presents to us with around 1% of women. And of those, about 30% are considered to be due to an autoimmune related cause. Now, possible explanations of this case, or more probable explanations rather, is that in autoimmunity, anti-zona pellucida antibodies that are causing the POI. So autoantibodies are to steroid-producing cells and enzymes, and gonadotropins, FSH and LH receptors, and the zona pellucida itself. So this conclusion I'd like to read from Koyama and in 2006 is that POF, preliminary ovarian failure, more recently referred to as POI, which is preliminary ovarian insufficiency, is a disorder induced by multiple ectopic factors. Since the zona pellucida was found around the oocyte at early stages of follicular genesis, it has also been considered as a causal factor of POF. This study showed that anti-zona pellucida antibody was detectable with high instances, 50% in POF patients, when using human zona pellucida as an antigen. The animal experiment revealed that homologous zona pellucida antigen could produce a self-reactive zona pellucida antibodies and causes ovarian disorder similar to human preliminary ovarian failure. We therefore have to take into consideration the fact that anti-zona pellucida antibody causes adverse effects on ovarian function as well as fertilization. So this is very important in realizing that we focus so much in the laboratory on perfecting our skills and our techniques. And some of the infertilities are just beyond our scope. We just certainly do not have enough information about them. And despite our efforts to become as close to perfect as we humanly can, we just are not able to combat all of the infertility that's out there. Next slide, please. So here's the take-home message to all of the embryologists that are either at the beginning stages of their career or even, techniques and skill set are an important aspect of IVF success, and proper technique and use is monumental in successful cell culture and outcomes, certainly. Facts versus myths. I mean, we are scientists and we should strive to find support in literature. So rather than, just word of mouth, and certainly, of course, if we're being trained, we certainly have to understand that training is coming from individuals that are seasoned, that so much more knowledge, and that's certainly very important. But going to the literature sometimes is key in understanding those gaps that we certainly just cannot explain in the lab. And some cases are just truly unexplained due to the limitations of data that are available in the literature. So IVF is pretty robust. However, it cannot solve all forms of infertility, regardless of the embryologist's techniques and skills. And so in the end, work hard and believe in yourself. And of course, being scientists and in the lab, our performance is directly related to outcome. And so it's very easy to point a finger at the lab, certainly if the outcome is suboptimal, but know that sometimes it is out of our hands, and we not all aspects of infertility are explainable. So with that, I say thank you for my time during this presentation, and I'm very excited to hear presenters.